Hi, my name is Saba Shaikh. I'm a breast medical oncologist at UT San Antonio, and I'm joined today by.
Yeah, I'm Junjie Li from Shanghai Cancer Center, Fudan University. So I'm a breast surgeon from the breast surgery department. Yeah.
And I'm looking forward to talking to you today about your interesting study. So, can you tell us a little bit about an overview?
Yeah. It's a prospective randomized phase 2 trial, and we focus on to evaluate a new anti-HER2 ADC SHR-A1811 in the neoadjuvant treatment of HER2-positive breast cancer.
And how is SHR-A1811 a little different than other HER2 targeting ADCs on the market that are being investigated?
Okay, so now there are so many different ADCs, and SHR-A1811 is also a HER2 direct ADC. So it's the third generation, and it's composed of trastuzumab and also a cleavable linker and the topoisomerase 1 inhibitor. The payload is a topoisomerase 1 inhibitor.
And what did the results of your study show?
Yeah, it shows just the monotherapy for this kind of the ADC, the efficacy is quite similar to the 4-drug combined therapy. So usually in HER2-positive breast cancer, we will use a 4-drug combined therapy. It's taxanes, plantains, trastuzumab, and pertuzumab. But now we can just use one ADC monotherapy to substitute it with a similar efficacy and also well tolerance.
And you also had an arm that combined a TKI as well, and it seemed that the TKI didn't add too much efficacy. What are your thoughts about that?
Yeah, it's a pity because when we designed the trial, we think the ADC is composed of the trastuzumab and the toxicity drugs. But if we can combine with the TKI, maybe we'll have a better result. But we still reduce the dosage of the TKI. For usually it's called 400 milligram, and we use the 240 milligram. But it's still the side effects is high and not improve the overall survival. But we also find it's quite interesting because in the primary stage 3 patients, so they have the heavy tumor burden, the combination group have the highest PCR rate. So we need to further investigate that.
Any unique toxicities that clinicians should be aware of?
Yeah, so different regimens may, of course, they will have the different side effects. For the TKI, diarrhea is the most we should take care. But for the ADC monotherapy, this is quite okay because just only one patient in SHR-A1811, we record a grade 2 ILD. So it's okay.
And I'm curious to hear your thoughts about the patients who did not have a PCR. They may go on in the future to receive an ADC in the adjuvant setting, such as Kadcyla, which is our current standard. What are your thoughts about ADC followed by ADC?
Yeah, it's interesting. And now we're really going some trials about the ADC combined with the ADC. Because, in the neoadjuvant treatment, we should take the best efficacy regimen. So if we use TCB-HP in the neoadjuvant setting, then with non-PCR, we can use ADC in the adjuvant setting, like the DB05, like the Catherine trial. And now if we use ADC in the neoadjuvant treatment, then maybe non-PCR, we can use TCB-HP just to combine with the chemotherapy and the trastuzumab and pertuzumab in the adjuvant setting. But in the future, maybe just ADC followed by ADC, but more easy to test it in the late line metastasis breast cancer. So after the TDXD for the second line or third line, and now we can try another ADC.
Yeah, definitely an interesting area. So any biomarker work ongoing to help identify who may be the best patients for this drug?
Yeah, that's really an important question because we collect all the tumor samples, blood samples, and we do multiomics analysis. And now in our preclinical data, it is quite interesting. We can identify the 20 or 30% of the patients. They are sensitive to any kind of the treatment, PCB-HP or ADC. But about 15 to 20%, they are just sensitive to PCB-HP, and another 20 to 30%, they are sensitive to ADC. And we can also find another 20% of the patients. We know maybe there are some target pathways, and we can combine, for example, the immunotherapy or even other targeted therapies. So that's why we will launch new trials to focus on that.
That's wonderful. And what is the future of this drug? What are the next steps that you all are looking into?
So in China, we have already launched 3 phase 3 nationwide clinical trials. The first is after non-PCR from the neoadjuvant therapy, just compare with TDM1. And also in the first line, and also in the late lines with HER2-positive and HER2 low expressions. So we have already launched some phase 3 clinical trials.
Well, that's wonderful. Well, thank you, Dr. Li, for joining me today. And
Okay,
congratulations on your wonderful presentation.
Thank you very much. Thank you.